am a pediatric dentist, so that is my main focus. However, I'm hopefully we have some general dentists on here as well who just want to learn more about peds because we love to have you. So we're gonna start right now. We're gonna go ahead and just talk a little bit about me. This is my fam here. This is my husband, Steven, and my little cutie Valor. He's 2 years and 4 months. Little crazy guy, always fun. And yes, I do come from Torrance. Right now I have a practice and it is in Cypress, California, which I mostly tell people is between Disneyland and Knott's Berry Farm. So here's our practice. It always look like this in sunny SoCal. And this is my wonderful team of ladies who make my life infinitely better. Today, we're going to be focusing on a few things. Here are the learning objectives. The billing, coding, and workflow strategies we'll get to at the end. Basically, we were supposed to have another speaker. Unfortunately, that fell through, so I'll touch on it a little and show you where you can find more information on that. So first, we'll just talk in general about lasers. Laser is basically an acronym similar to SCUBA. It stands for Light Amplification by Stimulated Emission of Radiation, which is pretty fancy. Basically, ordinary light that you see every day is made of many different colors and many different wavelengths. It's very unorganized and incoherent. So that's why it doesn't typically ablate any tissue or cause any issues. So how do lasers differ from that? Well, basically lasers deliberately energize a group of excited atoms, and this purposefully causes release of photons, producing a chain reaction. So rather than just being incoherent and a bunch of different wavelengths, lasers are coherent, monochromatic, and they're columnated. What that basically means is that it allows for selective absorption. And that is that you can choose which medium that the laser energy is absorbed by. And those medium are water, hydroxyapatite, and pigment. So you can see here that basically what that means is that different lasers, you can focus on different types of things. So right here, this color is the colored or visible spectrum here. Diodes are right after that. So diodes focus mostly on pigment. So you can see melanin is really high here and hemoglobin. You're gonna focus a lot on that, which is why they're fantastic for soft tissues. If you move on down, you're gonna see the erbium chromium, which is basically what I prefer. That is a laser that I choose to use. That is the Biolase Waterlase is what I use. So that's right here, and its main molecule to work on is water. It also can do hydroxyapatite or tooth enamel. And then if you go later down the spectrum, you can see the CO2 lasers, which basically were initially created for hydroxyapatite. So they're really high on that one and also do water molecules. So basically when you want to choose a laser, you're going to look at what wavelength you want to use. You're going to look at what you're trying to focus on. And again, this is just visible spectrum, diode right here, and then the erbium chromiums, and then the CO2. So what does laser energy do? Well, basically there are 4 different effects of lasers on tissue. The first one here is just reflection. So it just hits the tissue and it'll bounce right off of that. We don't really have a place for that in dentistry, so we don't want that effect. The second one is scatter or refraction. Basically that's when it hits the tissue and it bounces off into a bunch of different molecules, which is basically has no effect. So that is not that effective in dentistry as well. The next one here is going to be transmission. That's when it goes straight through the tissue. It doesn't have an effect on the tissue. It doesn't change it. And initially that didn't really have a place in dentistry either. It was great for eye surgeries when you didn't want to damage the eye tissue as you went to the back of the eyeball to cauterize. However, now we find that there is a role for it in something called photobiomodulation, which was previously known as low-level laser therapy. And we will talk about that at the end. And it's really great and fantastic, and I use it all the time. The last one, which we're really focusing on today, is going to be absorption. So that is when the laser hits the tissue and is actually absorbed by it. And that's great because that's when you can ablate the tissue. So how do you do that? You basically are going to match the wavelength to the tissue that you want to focus on. There are 2 different ways that you can do the laser, 2 different modes. So the first one is continuous wave mode, and the second one is pulse mode. So what that basically means is that The continuous wave mode, you set it to a certain power wattage and it'll do that the entire time without stopping. Oh, that can be detrimental to some tissues because you can cause lateral damage to soft tissue. And what that means is that you can basically injure the tissue, you can cause tissue to, damage to adjacent tissues. And that happens because while you're doing it the entire time, it's heating up the tissue. So then that can increase the tissue temperature, which causes damage. If you use the pulse mode, what that means is that you're going to set it to, like, let's say 3 watts. And then automatically, you don't have to do this. It immediately starts and immediately stops, immediately starts and immediately stops. You don't notice that this is happening. So it's not like you're taking a million times longer. It's just what that does is it decreases the tissue temperature, so that way you don't have as much lateral damage. This is just a picture demonstrating the different types of lasers and the effects that they have on the soft tissue. So I discussed the diode here. The diode's great for soft tissue. You do contact the tissue, so you have that tactile sensation, and you'll experience some carbonization. Carbonization is when you get that charred look on the tissue, and it will also denature proteins, so not always the best thing. And then the second layer, you'll have the coagulation, which diodes are great for, and then underneath that, you'll have some stimulation of the tissue as well. So diodes are fantastic for a lot of perio procedures because you'll get that effect. CO2 lasers here, you don't have any contact with the soft tissue while you're doing the procedure. You can get a lot of carbonization as well, so that charring, and then you do have the same coagulation and stimulation. As far as erbium, chromiums, like Waterlase, like I said, that I prefer to use, you have contact with the soft tissue when you use it, which is great because you do have a lot of the tactile stimulation, the sensation. And then, sorry, my staff just turned on the light. Can you turn it off? Thanks. But you do also get a lot of the coagulation and the stimulation as well, without a lot of carbonization. So that's fantastic because when you're working there, you don't want to see a lot of charring of the tissue. You don't want to get that smell of burning meat. It's never pleasant, and then it freaks the parents out as well. Here's another image of what I just discussed. So you can see here, you can see the diode laser here. You get that charring look. Again, you're gonna get that smell when you do it. I've done frenectomies with a diode prior to using the Waterlase, and you really do get a lot of that smell, and parents really do worry that you're hurting the child when you're doing that. Here you see NDI, you have a little bit less that, and then the CO2 laser, you get that as well. And then this is the erbium, you'll see you get it a lot less. You don't really see any of that, but you still are effective in your method. So when you're choosing a laser, how do you choose a laser? There are so many out there and it can be really confusing, but the baseline of it is that you're gonna wanna decide what are you gonna use that laser for. So if you're gonna just use it for soft tissue, there are a number of different choices that are great for just using soft tissue. For hard tissue, you're mostly looking at CO2 or the erbium chromiums, and that's because the molecules that they focus on are the water and the hydroxyapatite, so you're able to do both. So if you're looking for both soft tissue and hard tissue, then you're definitely looking at one of these that are also able to do the hard tissue. So in pediatric dentistry or when treating pediatric patients, why do you want to use lasers? Well, this is Dr. Linda Merzen-Dancer. She is amazing. She's the one who came and trained me, really great pediatric dentist in Colorado. She uses her laser every day, as do I. And the reason that we want to use lasers in pediatric dentistry is because parents are very familiar with a lot of things nowadays. They're able to do Dr. Google, which can sometimes make our lives a little bit harder, but they know about things. They know about technology. They know that lasers exist. And even if they don't know that lasers exist in dentistry, it's fantastic to show them, you know what, I have new technology. I made this great investment because I want your child to have the best and I want them to be comfortable during the procedure. And that's fantastic. It's a great referral source as well, but even more so, you're just able to show the parents that you care about their child by wanting the best for them. So I find that case selection is very important for certain procedures. For the most part, I can use the laser on just about anyone because there really is a very, especially with soft tissue, there's a very, very minimal discomfort with it. But certain things you do need to worry about case selection, as anything in pediatrics. So for pulpotomies without local anesthesia, which we'll discuss later, yes, you sometimes have to worry about case selection because there are some kids who, even if you spray the water outside of their mouth, they're jumping through the roof. Maybe not the best candidate for your first try. So just something to think about. Also hypocalcified teeth, which we can discuss about later as well. As we know, those are just incredibly hard to get local anesthesia on just due to their nature. And so sometimes you do have to think about that as well. So the most important thing when using lasers and anything in pediatric dentistry is just to tell them what's going to happen. Yes, you might have to use some euphemisms, make it fun, but that's what pediatrics is all about. So you're going to introduce them to the laser. Normally I show them it. People have names for it, like this is my Star Wars lightsaber, this is my Elsa wand, or something like that. You're going to show them, you're going to use tell, show, do for behavior management, as we always do. It's super important to let them know that they're going to feel something, but it's not going to be uncomfortable. What I do is I just show them on their hand this far away, actually using it, because it's not doing anything that far away, but they'll feel the water and they'll hear the sound. And so they'll know, oh, it's not hurting my hand, I'm good. And they'll be totally fine with it. So that's a great way to do it. And that's just how pediatric dentistry works. It's all about how you present it. And so with lasers, it's very, very similar to that. So, Waterlase is great because it just affords you the ability to be less invasive, a lot less invasive. You can do so many different procedures with it, and including frenectomies, which is mainly what we're here for. This is another dentist who just did her very first frenectomy in this picture, and the kid was, as you can see, perfectly fine after, no bleeding, no crying, happy kid. So let's get to the nitty-gritty of it all. We're going to talk now strongly focused here on frenectomies, and then at the end we'll get to some hard tissue and other functions. So what is a tongue tie? Well, a tongue tie, or formerly known as ankyloglossia, is a result of a short, tight lingual frenum. So basically that string underneath your tongue is really, really tight, it's really short, or it's in the wrong position. And this will severely impair mobility on a lot of children. It can cause issues with speech, it can cause issues breastfeeding, airway, growth, all of these different things. And that's one reason that we want to look into treating it. Back in the day, they used to have midwives who had one long fingernail, and they used to sweep them underneath the tongue of every baby, basically eliminating this need. But nowadays, we definitely don't do that, thank goodness. So what are some indications for these tongue ties? Well, this is from Dr. Larry Kotlow. The pictures are, he's fantastic, one of the pioneers in it, and a really great speaker. He's in Albany, New York. So I use his photos because everybody uses his photos in regard to classifications. And so here, what we're going to do is just talk about how do you classify them. So class 1 is here, and that's a mild tie. So you can read here these objective things, like the length is 12 to 16 millimeters. That's of the whole string, basically. What does that mean, though? So when I look at a tongue tie and I look at a tongue and I see, okay, this is a class 1, this is mild. Basically what that means is that I can elevate the tongue, either not, if not fully to the roof of the mouth, then very close to the roof of the mouth. I don't have any issues moving it around. It's not tight. You can literally lift it and you can feel that it's not tight. If you see some of the other ones, you'll understand that when you're lifting it, it feels very tight. So class 2 is a moderate tie. You'll find that it's like 8 to 12 millimeters, but really you'll see that, okay, it's not really strongly tied. I can lift it maybe 3/4 of the way to fully. They're able to speak well. They don't have any issues. When you lift it, it doesn't feel tight. Sometimes you do have to treat these ones, just depending on if they're symptomatic, which we'll discuss, but a lot of times you're able to kind of get away with not treating it because they've already compensated so long, so they're not having any issues. Class 3 here is it's a severe tie. So you will find that you end up treating a lot of these, and you'll find that it's very, very short. Maybe it's moved more anterior now. It's very strong, sometimes very fibrous. You can see it's a little thicker here in this photo. And when you lift the tongue, you're not able to lift it, maybe even halfway. It's very, very tight. Sometimes can cause discomfort. If it is an anterior tie, then you'll find that there's might be blanching of the gingiva or blanching of the tongue, or the kids just wincing because it's not fun for them. Class 4, definitely, I've only seen maybe like 2 that, you know, they've survived with it till they're teenagers and didn't have to be treated, but would still probably benefit from it. So these are very severe ties, usually an anterior posterior tie. So whenever there's an anterior tie, most likely there's also a posterior element. So it's something to think about. What that means is that anterior is obviously toward the anterior of the tongue, like the tip of the tongue. Posterior, you're going to find more towards the midline of the tongue. And sometimes those are harder to detect. You can't always notice them. So you do have to consider the symptoms as well. But if there's an anterior tie, you're most likely looking at a posterior as well. So you would have to treat both elements while you're doing the procedure. So these anterior ties are at the tip of the tongue normally. Sometimes you see a little notch in the tongue there. It attaches to the ridge, usually the mandible, actually gingiva, behind the teeth if they have teeth. Super, super tight. You can't even hardly lift the tongue. And it actually looks really uncomfortable for the kiddo. These are some of my cases I saw in the clinic. I've seen a lot of them, but you can see here that this tie is going to be more of like a posterior tie, but you can see it's really, really thick. This here is actually the frenum. It is not the tongue. So it's really, really thick. Kiddo wasn't able to fully lift his tongue, even 3/4 of the way, less than that, and was having speech issues. And then this little baby, anterior posterior tie, super tight, having a lot of breastfeeding issues. Another one, you can see this one visibly, super thick, especially for a tiny baby. A lot of breastfeeding issues, a lot of spitting up issues. And this is one of the girls I said who survived a long time with that tongue tie. Super anterior tie. This is her actually sticking her tongue all the way out. She wasn't able to extend it and it curled all the way under. And you can see here, again, super thick. She actually had this revised twice in her lifetime by an ENT. And unfortunately, it whatever happened, but she still has that tie. So we need to treat that one. This one, if anyone saw, you can totally tell that's a tongue tie. How he survived this long with that, I'm not really sure. But super anterior tie, really thick, and pulling so much on this gingiva here that he had a little bit of recession behind those teeth already. So what are you looking to evaluate? Well, there's different criteria when you're evaluating newborns and infants versus older kids, toddlers, or adults. So we'll focus first on the newborns and infants. So when you're seeing newborns and infants, what I like to do when they come into clinic is that I like to evaluate the diet, or the mom and the baby breastfeeding, if you're able to. If the parent is comfortable and they're able to show you how the child latches, definitely have them do that. It can give you a lot of information, and then you can evaluate how the baby is and how the mom's doing. You want to evaluate the baby symptoms. Do they have a little nursing blister, which I'll show you later, but basically that's a little white callus that you see on the lip up there, indicative of, you know, some issues with the latch. And then you want to evaluate mom symptoms. So are they having a lot of pain? Are they having cracked nipples, bleeding nipples, squish nipples? Is there a crease in the nipple? You don't necessarily have to go and look at that. You can ask them what they're experiencing. Do they have a lot of blocked ducts? Are they having issues with production and flow? And that will give you a lot of information, because if they are, there's probably something going on. And then you want to evaluate the child's health. Do they have failure to thrive? Are they having a ton of reflux? So little babies are actually not supposed to have a ton of reflux. Yes, their sphincters are a little less strong. However, if you will find after you revise it, their reflux goes down a lot, then you'll see that that's not actually supposed to be happening. You'll see a gas belly, which I'll show you a picture of shortly, but that's basically when they're swallowing so much air when they're feeding that they have all of this air in their belly, and it really expands and it looks all full and really uncomfortable for the kiddo. That often cause a lot of colic or crying because it's so uncomfortable to have that much gas. You can also see a lot of excessive spit up, and I mean excessive. You'll see a ton of spit up every time, maybe 1 to 2 ounces that they're throwing back up. That's not normal either, and that's because, again, all that gas is in there and it has to go somewhere. And so a lot of times it'll go back up this way, and that will cause them to spit up immediately after feeding. Then you want to evaluate clinically, classification of the tie. You want to check their suckling reflex. So you do that with your gloved hand. You insert it with your index finger toward the palate of their mouth, and you let them suck on it. And you see how's their latch. Do you feel their tongue coming all the way up? Does it feel really weak? And you'll get that with experience, but that's basically what you're looking for. Is the tongue going up? Do you feel a lot of resistance when you pull back, or are they just letting your finger fall out of their mouth? And then you want to check the actual extension of the tongue. So you're going to lift it upward, you're going to lift it outward, and you're going to see what's going on there. So this is just delving into a little bit more details about each of those things. So for breastfeeding, when you're checking the latch, you want it to be really deep. You want the child's chin to touch the mom's breast. You want it to be comfortable and relatively pain-free. And the child should be opening really wide against the breast, not just sucking on the very edge of the nipple. So if you've never breastfed or you don't know anything about breastfeeding, those are the things you really want to look for. So you can see here where the baby is really wide and totally on the breast there. That's more what you're looking for. You want them to be touching the areola, if not fully encompassing the areola, depending, because each person is different. And when you're evaluating the feeding, you want to see and hear the child swallowing. You do not want to hear any clicking, which is like after. And basically what the clicking indicates is that they're getting a lot of air when they're doing it because their latch or suction is being broken. So how about for all the symptoms that I was talking about? Well, baby, you want to look for that nursing blister. When they're feeding, do they splutter and choke a lot because their latch isn't good, so it's going everywhere? Do you hear that clicking noise? Are they not gaining any weight? We know that babies, when they first come home from the hospital, that they do lose some weight, but are they not gaining that weight back? Is their pediatrician concerned? Do they constantly want to feed? Are they every 30 minutes asking mom to feed? Not physically asking because they can't talk yet, but are they always showing the feeding symptoms? Is mom not getting any sleep at all because the child is waking up every 30 minutes to feed? Those are all issues and definitely indicators that something's going on. For the mom, is it really painful for them to breastfeed? Are they having blocked ducts? A low milk production, engorgement because their milk isn't, leaving their body? Are they having compressed nipples with the little creases, or a lot of bleeding and cracking? Those are all symptoms that maybe something's going on. So for health, you want to look at, is baby jaundice? So a lot of babies are born and have some jaundice, and that's okay, but is it not clearing? So with jaundice, one of the ways that it clears is that they have a lot of intake of milk, and then they're pooping out a lot of all of those extra pigments that the body can't break down, as well as, light therapy. But are they not able to get rid of that? Do they have failure to thrive or a low weight gain, so less than 3 to 5% on the height and weight? Do they have apnea or snoring? Do certain positions make it better? So not so much in newborns, but in older babies once they can sleep on their tummy. If you see the kiddo in a TP position like that, it's something to think about, because normally they sleep in that position because their airway, something's going on, and that allows them to get a more clear airway to breathe. So if you see that, it's an indicator. Is the baby super, super colicky? Do they never stop crying? Do you have reflux issues, excessive vomiting? And then this is that gas belly I was discussing. So you'll see it's really, really big. You can tell it just looks highly uncomfortable. Is the baby sleeping with their mouth open like that? Babies aren't supposed to sleep with their mouth open. So it might be an indication that something's going on with the airway, possibly due to that tongue positioning. Here are some of the clinical signs we're going to discuss. So you're going to look at the classification, like we discussed earlier. You're going to look at the ability to suckle, as I told you about putting your finger there. You're going to pull that tongue out all the way, and you're going to pull the tongue up all the way, and you're going to see if you are having difficulty doing that. Is it really tight when you're doing that? You want to see if the tongue curls upwards as you extend it out. So you can, I'll show you in a minute, but when you put the tongue out all the way, if the sides curl up, that's a sign that something's going on because it's really tight. So the tongue just curls up automatically instead of going out and flat all the way. Do you see a little notch in the tongue? This is a great picture of a kiddo who had a little notch in his tongue. You can see it forms a little heart here, and you can actually see it from this side and this side. So that's a tie right there. Do they have a diastema between these lower teeth if they have those little teeth already? And is that frenum attaching there? And that's why it's causing a little diastema. And then you can also see recession of these gingiva if they have the teeth already. And you can see the blanching on the lingual side of this as well. These are actually two little babies who I haven't treated yet. I'm seeing them later today as an emergency because they are not growing. And so this one here, they just sent me photos, and I was like, these are great because these show this baby is fully crying because it was in a video, and you can see his tongue is not even getting halfway up there. So that is a tie. You can see right here the attachment. It actually notches a little right there on the anterior, and it looks really, really tight and short, so most likely we'll be looking at that procedure. This is another little, only a week old, but the pediatrician was super concerned because he's losing so much weight, and mom says that she is not able to even get any sleep because this kiddo's feeding every 25 minutes. So super tight all the way to the anterior there. You can see it looks really short, and so he's definitely having a hard time latching. The way that you evaluate these little infants and newborns is that you're going to do it in a knee-to-knee position. And it's really, really important to do that because it allows you to fully visualize and also to do those exercises with the tongue that I was talking about, lifting it upward and outward. It's just not possible to do when they're in the parent's lap like that because you can't get the right positioning. It's also really important because the parent can see what you see. And so that's really great. So if you just lay them all the way back or do a full knee-to-knee position with loops and light if possible. Some of these littles are really, really crazy, as you guys know, so that might not be possible, but it is really the best if you're able to. And then you just sit behind the head, and the parent's basically holding the child in their lap on a board, and you are able to show them look here, I'm not able to elevate the tongue fully. Look here, you see this little string underneath the tongue. It's really, really tight. And so that way they're able to understand where you're coming from as well. You want to lift the tongue using two fingers on one finger on either side of the tongue, and you're going to pull that tongue towards your stomach, so up and backwards. And then you can demonstrate at that time, if for sure the parents know they want to do a frenectomy, like if they came in specifically for that reason, you can also at that time demonstrate the exercises that they're going to have to perform after the procedure, because it really helps them to be aware of what they're getting themselves into, because that part is the least fun. And so I'll show you that at the end. That's actually part of the speech I make to the parents, letting them know that the hardest part is going to be at home after the procedure, because they need to do these exercises, and kids are not exactly the most cooperative when it comes to that. So what about older children and adults? Well, you're really looking at that point on treating symptoms, because they've most likely compensated for a very long time. So do they necessarily need it? Well, it just depends. On toddlers, are they having speech issues? Do they have a speech delay? Maybe you should definitely check at that time. I actually check on all my kiddos at their first visit. And then on the older toddlers, if they're not able to sit for it, on their first visit, I always ask the parents, are they having speech issues? Do they have any delay? And if they do, then I make them do the knee to knee, and I check it that way. So you want to look for that speech issues and delay, because sometimes on these 3-year-olds, after we do a release, they come back in there for their week checkup, and they've seen the speech therapist, and they're a whole different kid. Or a couple months later, they'll have an explosion of their lexicon because they're just able to speak now, so they can say so many more words. And it's really amazing when those kind of things happen. Is the patient themselves, like the older ones, are they unhappy with their tongue control or their extension limits? Some kids are just embarrassed by it. They can't like lick a ice cream, or they're just embarrassed by it. And so they may want to have that treated. Do they have apnea or airway issues? If so, and you don't see any really obvious tonsils or grinding or other issues that would worry you specifically about having sleep issues, or they've already had a sleep consult, then it's something to consider at that point. Oh, maybe this is one of the issues and one of the reasons why they are experiencing this. And then, of course, for aesthetics, for diastemas, for ortho purposes, do they have that lip one? Do they have that tongue one causing a diastema between the lower ones? Do you need to treat that at that time? Is it going to make a difference for you? And those are all reasons to think about. Also, in consultation with your orthodontist, if they're like, do it, then it's a good indication. So this is one of the cases I did, really obvious. So I like to show you the older kids' cases because it's easier for us to visualize since they're bigger and they sit a little more still. You can really, really see them. So this kiddo is 10 years old, super, super, super anxious kiddo. Would barely sit in my chair the first time he came. So we did do nitrous on him when we did this procedure, but it was fantastic. No crying, no pain, no complaining, which I'll show you in the video. But you can see here that curling of the sides of the tongue that I told you about, super anterior tie here. You can just see it automatically. You can see that it goes all the way here. When it inserted, the lingual gingiva was blanching, has an anterior and posterior component. So you can see the tongue curling all the way up like that. Can't even lift it halfway. Super strong indicators. Post-procedure, you can see, whoa, we can elevate that tongue all the way up there. It is super flat. You see our little diamond shape there, and awesome release. This is a video of it. It's a little blurry, so sorry about that, because when it was so big, it got a little blurry, but I will talk you through this procedure. So like I said, super anxious kiddo. We did apply the best topical ever, or compounded topical. You can use any compounded topical. That's the one I use. That's all we needed. Again, the nitrous was because kiddo was super anxious, would barely sit in the chair. So we have a bite block going in because he was fairly cooperative. So we just needed a bite block. I'll show you some other alternatives if we need it. Here, what we're doing is we're elevating the tongue with a little groove director. And then we are lifting it, and I was releasing the vertical. So I will show you in a second. And I did this one a little different than I normally do. Normally I would be done by now, but I kind of wanted to show you guys what it looks like in the middle of it. So we are doing a release of the vertical. So I basically go from the midline of the frenum, and I go up and down vertical to release that part of the frenum. And then I have him open really, really big just to show you guys. So we release part of it, not as curly on the sides of the tongue, but you can tell it's still really tight. So now we have to do the posterior portion of the release. So bite block in, we have double suction because when you're doing it, there is water. So we want to make sure that we're suctioning all that water. We don't want the kiddos to be swallowing or aspirating any of that. Also, he was doing his tongue running away from me. And that's one of the issues with the bigger kids, is they can move their tongue a lot more. So a lot of times that they'll run their tongue away, I'll kind of pull it away. So that's why it's great to have this groove director. It allows you to hold that tongue up and really get in there and control it as much as possible. Because we took that break, I applied a little bit more topical. Normally, like I said, I apply it once and that's it, then we're done. So applying that topical, and then you can see already the tongue is lifting a lot more. So now we're doing the vertical release, like I said, and then what happens is then you do a horizontal release to make that diamond shape. But when you do the horizontal release, what you're doing is there's a natural place you'll find as you lift the tongue up that where the horizontal release goes. You do not want to aim your handpiece toward the floor of the mouth because there's a lot of blood vessels there and you don't need to. You're just trying to release all the tissue that's really tight, and that will allow the mobility of the tongue that you're looking for. So lifting the tongue up, you're going to do it up and down, and then you're going to do the horizontal release, and then you can try it again after. Skip the end of that one. Anyways, he did fantastic. A full release like I showed you in the photo. What about lip ties? So as far as lip ties go, these are classifications again. So class 1, you're going to see normally it inserts above your MGJ, your mucogingival junction here. You can fully lift that lip up. You don't have any issues, not tight at all. For the second one, you can see that it usually inserts into the freely moving tissues, but you'll normally see that you don't have any blanching when you lift it. You can still lift it pretty high with no trapping right here in the vestibule. Class 3 is the papillary insertion type. So you can see it inserts right there. If they had teeth there, it insert right between those, usually causing some kind of diastema, and it'll be really tight. So there'll be less of space between the vestibule when you lift that lip up fully. And you really have to lift that lip up in order to check for that. Next, you're going to be looking at the class 4. That's the one that goes through the papilla, so papillary penetrating, usually super fibrous and thick. You'll see that right here, you have that trap right there. A lot of food or milk gets trapped up there oftentimes. And so that's the most severe. These are some kiddos that I saw. You can see super strong here. This one, I can't even lift the lip up all the way there because it's so tight, already causing that diastema. You can see it going all the way through there. And you're gonna end up with a higher caries risk here because you can't cleanse that, especially when the kids are doing their tighten up their lip thing that they do when you brush them. So definitely maybe something to consider doing it on there. Also, if they do have some latch issues, that can also be a contributing factor. Another one here, really thick and tight here. That one was super thick. A lot of times you'll see it like this. Really wide V, wide insertion there. All of this blanching between these two teeth here. Really strong indicators of a lip tie that can be treated. Even though he doesn't have a diastema, it was trapping so much food. And then another one here, you can just see right here, I should be able to see the vestibule, and I can't because it's just too strong and really tight, and then a huge diastema. You can also see right along these gingiva right here, all those incipient lesions. That's all indications because of the cleansability factor from that frenum holding that lip in. So what are some indications for treating lip tie? Well, speech issues, yeah, lip tie can contribute to that for sure. Breastfeeding issues, caries, if it's just really hard to clean, and then if they have that diastema for aesthetics, all indications for you to treat that as well. If a kiddo has both ties while you're in there, it's good to maybe just treat both so you don't have to bring them back to do the lip one later. It'll have less severe impacts on speech and on breastfeeding issues, but definitely can still be a contributing factor. You also have something called Mandibular Labial Tie, so that's just your lower. You'll see it there. A lot of times it'll present right between 24 and 25 or O and P, especially in those with really shallow vestibules. And during the lip movements, what happens is that the frenum is attached to that lip there. So while you're moving, talking, eating, it's pulling on that frenum, on that string, and it's causing some of the fibers that are inserted on your gingiva to pull too. So you'll get a lot of perio issues, you'll get pocketing, recession, increased caries risk because again, it's trapping food as well. And you can also get a big diastema between those two teeth there. Buccal ties are also a thing. So it's the same thing on the upper. You'll see right in that buccal vestibule, you'll see a tie. A lot of times they're not of consequence, but some can increase your caries risk because you can't brush right there, or they trap food there, and then it can also cause some latching issues. So if you see one that's really strong, you can release it while you're doing your other releases as well to really help mom be able to latch. This one here you can see is really, really good, but you can still pull the cheek out, so probably not an indication to treat it, and this one has a little tissue tag on it. That can happen sometimes too, especially if they fall and sever their frenums, but not all the way. It can get a little tissue tag on it. Not really a huge deal, but just something to be aware of. This is one of the lip ties we release. So he has a giant diastema, and then also was having a lot of issues with the food trapping up there, which he didn't like personally. Older kid again. And so we did a release, and I didn't pull lip all the way up, but you can see a nice little diamond there without bleeding. This is immediately after. So this is just an example of how we do the procedure. Again, easy to see. We still use a bite block in our older ones because it allows you to suction really well and not have to worry. You can do it a lot quicker. So I applied lots of topical on this kiddo. Super anxious again, but really, really cooperative because you show them on their hand, tell, show, do, and then they're happy about it. So I showed him in his mouth. Oh, this is what it feels like. This is the spray. He's cool with it. We went right in. So again, I start right in the middle. Some of the videos show starting at a different area, but I find that that's the easiest because you'll really start to feel the pull, and you can really start to extend the lip so you can see where you need to provide that horizontal cut for the full release. So here we're doing the vertical cut. Don't worry, we'll talk more about this soon. Here we're doing the vertical incision, releasing all of those tissues. Now, when you open up a frenum, what happens a lot of time, especially if it's a super strong frenum, is you'll see like 4 or 5 little strings in there, and you need to release each of those little strings. Some of my ones that I've seen that are really, really strong, you'll see like 10 little strings in there. So you'll want to release all those little fibrous connections in order for you to get a full release. So you can see in there, see all the little different strings. There's about 4 or 5 of them there, like a little guitar. So you want to release all of those. And then you can see when I'm pulling, see how there's a natural area that you can tell that you want to put that horizontal release. That's what you want to do. Now for the lip, in order to avoid excessive bleeding, you don't want to aim the tip of this into the vestibule because that's where all the blood vessels are. You don't need to. You just want to release these fibrous little strings here that are causing it to be really tight. So we do the horizontal cut. We do it closer to where the gingiva are and aim it more downward so that you have less bleeding and that you don't worry like, oh my goodness, I caused excessive bleeding. What do I do? And then you can really see. So releasing, we pull it. We see a little bit tight still, but pretty good and very minimal bleeding. So we went and released these little strings extra afterward. Super easy. So how do we do these frenectomies? How do we do these procedures? Again, just showing you, all the different ones that we have. The fact that there's your submandibular gland right there. So again, don't aim it into the floor of the mouth when you're doing it and you'll be fine. So what do I do? So pre-procedure, I have the staff prep the parents on what's going to happen. So these are mostly for our patients who are calling and saying, my kid has a tongue tat, I need to come in, I need to treat it, especially for our new moms. So I have the staff prep them. I let them know, when you come in, we're going to do an evaluation. If you want to do the procedure the same day, this is what's going to happen, X, Y, Z. And we'll go over that. And then I have them do a couple things. So first, I ask them to please, if they're able to, not breastfeed for 20 minutes prior to the procedure because I want the kid to be as hungry as possible afterward. Now, when I said I want to evaluate the breastfeeding diet, you don't let them fully breastfeed when you're evaluating. You let them latch and have a little bit, but then you're like, okay, that's enough. I saw what I need to see, let's do it. And then you let them fully feed afterward. I let them sit in the room and feed for as long as they need to. And then that allows them to see, oh, it's so much more comfortable or what happened. So I asked them to please avoid that for 20 minutes prior to the procedure so the baby's really hungry. I asked them if they're able to please pump 1 or 2 cc's, so just a little tiny amount of breast milk, and bring it. And what we do is we take a sterile syringe, we fill it up with that breast milk, we put in the freezer while we do the consultation. And then afterward, I just squirt that breast milk right on the wound, healing properties, comforting, all of the good stuff. If there's any liquid gold left, I put it right back in that bottle because it was sterile syringe, totally fine. And then for the parent to take home. And then I have them bring that in. And then the last thing I have them bring is InterSync pillow. So we do have one at the office. However, because we're dealing with a lot of newborns, I just want to reduce the risk of contamination or anything as much as possible. So I have them bring their own if they have one. And then we send them, of course, new patient paperwork and a form, which I'll show you in a minute. And then when they come in, you're going to evaluate them fully. all of those things we discussed before. Usually, I like them to have seen a lactation consultant if they're new and breastfeeding issues, or if they're older toddlers, a speech therapist or oral myofunctional therapist before doing anything. Unless you can see it's a very severe tie with an like emergency, like failure to thrive, then that's a different story. But the reason is because, so for toddlers, what happens is, or any kid, but what happens is when you're in utero, you're already developing your suckling reflex. You're already developing your tongue movement. So that gives you an extra 9 months of compensating if you have a tongue tie on top of however old you are. So let's say you're 3, then that's almost 4 years of compensating with your tongue. So if you're able to get them in with a speech therapist and an oral myofunctional therapist, then they can get back in with them right after the procedure so they can reteach them how to use that muscle. So remember, tongue's muscles, and it's like you say, if you've been compensating for that long, or even just 9 months, it's a long time for you to have to retrain that muscle from all that time that you've been using it differently. So it helps to have someone show you what you need to do to accomplish what you're trying to accomplish by doing this release, by doing this surgery. And also, if it's not a really strong tie, like a class 1 or a class 2, but you're having issues or symptoms, maybe it's best to see if there's another way to treat it more conservatively without having to do a surgery, but not if you have a 3 or 4 tie. Different story. So you want to go over the procedure with the parent in full. I also demonstrate the post-op exercises like I told you before, because that's going to be the most difficult for them, and they have to do it all alone at home. You're not there to hold their hand, so it helps for you to actually demonstrate it for them. You can do it right after the procedure, but usually babies are crying, so you might not want to do that, or you can just do it before while you're doing the exam, and that's really sufficient as well. I always also like to document and take photos, before and after photos. And the reason for that is because you really like to, the reason for that is because you want to make sure you're able to show the parent, this is what it looked like before, this is what it looked like after. Also for billing purposes later, sometimes they do ask you for those photos. And then I like to have the parent, like I said, set up that appointment for the same week if possible with the lactation consultant, which is IBCLC, or the speech therapist, or the oral myofunctional therapist. Those are all really helpful, again, to retrain that muscle. And then you want to do risk benefits, alternatives, and informed consent. I always let them know that their alternative is to see a medical ENT. You know, it's great if they want to do that, if they want to pursue it, go through their medical insurance that way, especially if they have like an HMO plan, and then they can choose to do it that way. I let them know, you know, you're totally welcome to do that. It's a great option. If you want to seek a second opinion from them, great, do it. I do let them know that I haven't found any around here who really do it with laser. A lot of them will do the way that they were trained, which is more traditional and still works, with a scalpel or scissors and sutures. So on tiny babies, sometimes that requires general anesthesia. I just let them know that, you know, that might be a thing, but call them and see what their typical procedure is, and decide if that's what's best for you. A lot of times they're like, nope, laser all the way. So again, but it's always great to let them know that that's an option. And then I always also let them know that it's going to heal white inside the mouth. That does not mean infection. That's how the mouth heals. So if they see that white forming, then that's good. That's what you want to see, because parents freak out, and inevitably you'll get some calls about that for sure. This is the evaluation form we use, especially for newborns. For toddlers, like I said, a little bit different, but for newborns, just your birth history. Did they have their vitamin K vaccination at birth? Because you don't really want to have those issues with bleeding. You don't want to have post-op issues if you can avoid it. So you want to know if they had that. If they didn't, it's up to you and your discretion if you want to choose to not provide it and have them seek maybe an ENT opinion. Birth weight, current weight allows you to evaluate, are they growing? Do they have failure to thrive? Is there any issues? And then feeding issues, you can see there, it's basically everything I discussed already. Same with health history, and then mother symptoms and child symptoms. These are the forms we send to them, or we have it here in the office, and it just helps you to have some documentation and to really fully make sure you addressed all of those things that we discussed earlier. Consent form. I'm happy to provide anyone who would like a copy of this if you guys need it, because sometimes I know it gets a little confusing finding these things. So what about setup? Well, for setup, what I like to do is use, obviously, my preferred Biolase, and then I either use this round tip or MZ6, but my preferred is a chisel tip or MC3. So it looks like a chisel, and so it allows you to really see what you're doing and get that precise cut. But you can use either. They both work fantastic. Mouth props. So these foam rest ones here, they're from Specialized Care Co. Both of these are, which is a fantastic company and really has these great items. So they treat a lot of special needs. So here we go. Foam rest. Your assistant can really get in there. They make extra thick for those biters. And it just allows you to have more control. And this is for like your little ones who aren't going to keep a bite block in. Your other option, which is really fantastic, and I found recently, I love it. It's also from Specialized Care Co. It's autoclavable. It comes in multitude of sizes. It's this bite block with a handle on it. So you can go ahead and hold it in with a handle. And also it has a hole for you to stick the smaller suction in. So that will give you that suction there. And then your assistant can hold that and then the bigger suction. So really fantastic option. I love it. And then Groove Director. Honestly, I just bought mine off Amazon for like $3, but there are a multitude of options. You can call your dental people who give you products and find out from them how much their Groove Directors are. They come in many different sizes. I have many different sizes, just depending on the tongue size. Smaller, you really need a small one though if you're gonna want to treat infants or babies. And then of course suction. You're gonna have gauze because as you'll see, like I use a lot of gauze afterward, just if you want to visualize it again. There is a little bit of heme, but it stops really, really fast. And then therapeutic device or papoose for your older kids. Now, I don't use papoose in my practice except for these procedures. And so it just depends on where you're located and how accepted it is. But for me, therapeutic device on toddlers is much better because parents can't hold them while you're doing this and their heads get in the way when you're doing the procedure. On newborns, completely different what I use, I'll show you. But on my toddlers who are having speech issues, those guys are like little strong monsters. So you really, really need something that's gonna help to stabilize them. And that's all for their safety. You wanna make sure you're doing your job as fast as possible and that you get in and out and the kid's safe with no bleeding, no issues. And so that's really the best way. Other things that I like to use are head positioners. So I just have gel head positioners. And then that just helps to stabilize the head a little more without having to actively stabilize it. And then eye protection. So with the laser, of course, you want to have eye protection. So what I like to use is for the littles, I like to have the baby goggles that has a little side toggle. It has a toggle, I'm sorry. And the reason is because you can move it to the side and put it here instead of putting it on the back of their head where they're laying, so they don't get a little indent on their head. And then for you, if you're going to use your loops, which I highly recommend, you're going to have a little clip in. So it slides right in between your loops and protect your eyes while you're still able to use your loop function. The companies that do that are Innovative Optics, Laser Safety Industries. Those are the main ones, but I'm sure there are others as well. So on infants, what I like to do is I like to stabilize them with a swaddle. My preferred is called the Ollie Swaddle. And the reason is because it's super fast, easy, it works. My kid was a Houdini and this is what I used on him. And also you can use it on a range of sizes because it's not size specific. So some of the swaddles are size specific, and that's going to be an issue because you're going to have to keep a whole bunch of them. So I just have a whole bunch of these ones, and it's 3 Velcros. And so you just go like this and make sure their arms are down and it Velcros them. And then the bottom has a little elastic tie that you just hold it together so they can't get their little feet out. And then you either use a lap cushion board, which if you're a pediatric dentist, you have one of these. And that's for like a knee to knee position. Or what I chose to use is just this Bumbo board because it has a little strap. That's a changing pad. It's a thick foam changing pad, almost the same material as a lap cushion. And the lap cushion you can get at Specialized Care Co as well. The Bumbo pad you can get from Amazon. So this one here is it's just like I said, a changing pad. It's foam, it's sturdy, and I lay the chair all the way back and put it on that, and then you can strap them in to make sure they don't go rolling away. So in infants, I don't use any topical because they're so tiny. And sometimes, like I said, they're a week old. You don't want to use any stuff, especially if you don't know, if they have reactions to anything. So no topical. It's fine. It doesn't hurt. I've done it on bigger kids with no topical either. But in bigger kids or adults, you can use the compounded topical. And like I said, I use the best topical ever. That's what it's called. I'm not just saying that if you've never heard of it before. And then you want to make sure they're positioned. So you want to stabilize them either with the swaddle on the flat surface or therapeutic device. In older kids, like I'd say like 9, 10 or older, you can do nothing. You can do nitrous if they need it. Or you can do the pillowcase method, which if you've never heard of, you make them bring their own pillowcase. You put it behind them, you put their arms in it, and then you have them lay on it so that their arms can't go anywhere. That's always an option too. And then adults, nothing, or nitrous if they're super, super anxious, if you choose to treat adults. As far as head positioners go, like I said, we're looking at the gel head positioners. They have a bunch of different kinds. They have foam. You can get them from a medical supplier like Medline, although at this time it might be kind of difficult. So assistant positioning. So typically I have 2 assistants available. One suctions and pops the mouth open, and the other one either stabilizes the head if they're, too much, or they're just there as an extra pair of hands and can keep one hand on the child just to make sure that they're extra safe. So once you stabilize and position your child, you're going to prop the mouth open. You're going to make sure you're suctioning. For the tongue, you're going to have that groove director that I showed you. You're going to pull that tongue upwards and backwards towards your stomach. You want to fully extend that freedom. So make sure you are putting a fair amount of pressure, not anything aggressive, but nice and firm to really get that freedom extended. And then for the laser I use, we're going to do laser setting. It's going to be Frenectomy on rapid cut. You just want to go fast and it doesn't hurt, so you're good. You're going to use the laser to cut first in the vertical direction along the frenum. And then, like I said, you're going to do that horizontal cut, and that's going to release the sides, and it's going to create that diamond shape along the towards the floor of the mouth, basically. And there's going to be that natural place. Like I said, when you pull, you can really see, okay, it's already starting to kind of buckle out on the side there. That's where I need to release to allow it to fully be able to move. This is Biolace's technique demonstration animation, so you can really see it. I actually find that it wasn't a full release in this video, but I'll show you exactly where. So it's actually a good demonstration. So this is for the tongue. So they're using a hemostat, so it's a little bit different because your groove director would go on either side of this right here. So I actually don't want to start from here because it's very difficult for you to see what you're doing there. And also, a lot of times we don't have to release all that far. So what I do is I start from the middle here, and then I go vertical here. And so basically when they're saying this, they're done with this. But no, you can see that there's still, they release the anterior portion, but not the posterior portion. So what I would want to do is I'd start in the middle, I'd go up and down vertically to release that. And then I would go right here. That's the natural place where you would want to release that that horizontal cut. You can see it. You need to release that in order to allow this tongue to move fully. So I would go ahead and release all of these fibers here on either side, and that would create that beautiful diamond shape and also allow this tongue to fully move forward. This I actually wanted to show you guys because it's a toddler. Toddlers are the hardest ones to treat because they move so much. They're super independent and have really good, strong wills. So it's going to be a lot more of a rodeo than you would see with like a newborn or a bigger kid like I showed you earlier. But I think it's good to get a realistic vision because before I started doing these, I didn't have a realistic vision. So it's good to know, especially if you're in PETA. So this is my little toddler who was fun. He was actually good. So his head didn't move much. He just cried, but that's fine because I know we're not hurting. They're protesting actually because you're holding their tongue up and they don't like that part. That's actually where I get the most protest. And so I just let the parents know that in the beginning. They're going to cry because I'm holding their tongue, but it doesn't hurt. And then they're usually fine with that. So we had him propped, we had the suction going. Also toddlers can move their tongue around a lot. So he's running his tongue away, but it's fine. Basically, and he also bites really hard. So he's really getting through our foam stick. So this is where that other one would have came in really handy with the suction on it and the handle. But anyways, he did fine. So we do the vertical cut, and then I'm just showing you this again to show you that sometimes it's not as fast as you want it to be, but it's still really fast because this all took like less than 2 minutes, and even though he was not being the most cooperative toddler. So that was a full release right there. So you can see it's super fast still, even when they're being a little silly. Another toddler, a lot of speech issues with this kiddo. He was crying like this even before I touched him. So even when he walked into the room, so he just likes to protest, and that's okay. So lots of suction, and right here we're doing that vertical release here. Natural place will do the horizontal. He can already move his tongue way more. So this kiddo, he came back to me a couple weeks later, and his mom said that his speech therapist was amazed and said he was a completely different kid. And she was so impressed that that really made such a difference. And so it was fantastic to be able to hear those kind of results from such a simple procedure that you're able to do. Again, so I just keep gauze on hand because sometimes when they're moving a lot, you get a little more heme than you want. And so that's okay though. Right after we just use the laser on the laser bandage setting, and that causes hemostasis. Again, done already, super fast. So these are some of the cases befores and afters that I can show you that we did. Super strong tie here. You can see full release, able to fully elevate that tongue now all the way to the palate, flat on the palate, which was great. This was that kid you just saw who was crying a lot. So super strong posterior. And then afterward, he wouldn't let me grab his tongue fully, but it fully went up to the roof of his mouth. And then this is the first case you saw. So posterior tie, not anterior. So again, harder to detect, but having a lot of speech issues, and afterward was great with speech. So you can see here, nice diamond shape. You can really see the difference. And it looks deep, but it wasn't. Super easy and no bleeding. This is right after. So for the lip and the buckle tie releases, you're going to do it very, very similar. You just don't use a groove director. You either use your fingers to extend that lip or gauze. And then same thing, vertical cut along the freedom, horizontal cut to make that diamond shape. Don't extend it into the lip and vestibule, or you can get the excessive bleeding. So what happens if your kid is excessive bleeding anyways? Well, what we usually recommend, or what I usually recommend, is not to use silver nitrate, which some people use. And the reason is because it stings really bad. And also it makes it all black after. And so it's really kind of frightening looking. So use the tea bag method that we've learned throughout school, you know, soak that tea bag, let the tannic acids work and help that hemostasis and that clotting. And that helps a lot. Or of course, pressure, if they'll let you. So this is the lip one, technique animation. Okay, so for this, again, I would start more towards the middle, just because it allows you to visualize more fully, and really will allow you to pull the lip more as the freedom releases itself. So, and also it's kind of hard to start down here because you don't really know where it's inserting. So it's easier to do it up here. So middle, and then you're gonna go ahead and release. And then when you're doing the horizontal, like I said, you're not gonna be up here. If you cut in here, like you might need to release this a little more, but you're not gonna go into the vestibule because that's where all your blood vessels are. So you're gonna create that little diamond shape. You actually, a lot of people will be like, oh, do I need to notch the bone if it goes all the way through? Actually, no. I find that if we just release all of the fibers enough right here, you don't need to notch the bone because you're not pulling here anymore. So actually the teeth can close with your ortho and it won't pop open again. So that's nice. All right, and here's how to do it on a little tiny infant. Kiddo's only a few weeks old. So Ollie Swaddle on the bumbo. These are before I got my awesome toggle glasses, so they're a little less stable goggles, but super fast. I did a lip release here, up and down vertical, and then, you know, we don't even really have to prop this little one open because he's pretty much crying, so it's okay. And just suction. Done. Super fast and easy. And then I also did a tongue tie release on him, able to eat and do everything really, really well. Sorry. Oh, there's another kiddo. So this little kiddo was not that cooperative, but we were able to release it. So you can see how quick these procedures are, even if they don't hang out with you. But I just think it's good to get a realistic feel for it. The big kids are going to sit and it's going to be fine. I know I'm not hurting these little ones. And as long as you make that clear to the parents, and they're going to be totally fine with it as well. So you can see me releasing the side. So this kiddo had about 10 strings in his little frenum there. So it took a little bit longer, but still really fast. And then he was able to eat so well after, and speak really, really well as well. So what about post-op? So post-op is super, super important for you to discuss with the parents, because they have to do these exercises at home. And if they don't, then it can reattach. And then you're going to have to do a revision in a week. And the kids are going to be even less cooperative because they're like, wait, I already been here. I don't want to do this again. So you don't want that to happen. So remind the parents that the healing, again, reiterate, the healing in the mouth is white. This does not indicate infection. Infection rates are super low with this, actually. You want to follow up in 1 week to see if that revision is required, which, like I said, will only really happen if they're not doing the exercises at home or not doing it efficiently and effectively. So after the week, you do encourage them to do the exercises for another week, but usually healing is more near completion by then, so you don't have to worry as much. But I do encourage it, just make sure that you're fully getting that healing in the right position. For toddlers and older, you can also tell them to use some analgesics if they need it. So Tylenol to prevent pain the rest of the day, because usually they're usually only comfortable for about a couple of hours right after the procedure. But especially when doing exercises, you're basically having a wound that you're opening again. So you really want them to be comfortable, and toddlers complain more. So a little bit of Tylenol for like the first day or two, and they're fine. Newborns and infants, you can use coconut oil if they don't have any allergy, Camilla oil, so Highlands makes Camilla oil drops, or even sucrose solution for really baby newborns. They're sold in little sterile packs like eyedroppers, and it's called Sweetums, and you can order direct from them or from Medline. So what are the instructions for exercise? So basically, each exercise you're going to have them do in repetitions of 3, so 3 times, but 4 times a day for usually about 2 weeks. So the first one here is you're going to lift the tongue with 2 fingers, or for lingual, for a newborn. You're going to lift the tongue with 2 fingers until your diamond is fully visible. Make sure they do it until it's fully visible, and then just release it. Then the second one is you're going to massage around it, and then you're going to swipe your finger through just to make sure that it's not reattaching. And then next, you're going to have the baby suck on the index finger, and you're going to pull back a little and make sure that they're sucking it back in. That's going to help to strengthen that tongue and that muscle. For the tongue for about 3 to 8-year-olds, it's a little harder because they have teeth and they can bite you, and also because they're not as cooperative. So if possible, you still want them to do that tongue lift with the release. But if it's really not possible for them, then the other option is to have them do find the treasure. So what they do is they basically will sweep their tongue on the maxillary vestibule all along the buccal surfaces of the teeth. So like, and that's going to help to really stress that tongue. And it's fun for them to find the treasure. There's no real treasure, by the way. And then the second thing is you're going to have them fill a little shot glass with something yummy. Yogurt, preferably. But if they really can't get them to do with that, something like chocolate syrup or something not recommended by pediatric dentists. And then you're going to have them try and stick their tongue all the way down into that glass to lick the substance. So get it all the way there. And then that's fun for them, and they'll do it. And then the last one is you're going to hold a stick, or if you really can't get them to do that, like a sugar-free lollipop. And then you're going to have them try and lick it all the way up right on their nose. And that will help do all that stretching for you. For the lip, you're going to do something very similar, lifting it to expose that diamond and then sweeping under. Super easy and more accessible. Any questions?
Thank you, Dr. Learn, very much. I appreciate the great pace and all of the terrific information. We actually do have quite a few questions. So what I'll attempt to do is start from the beginning in terms of how we, when we receive them. There are several that seem to be in groups as you've gone through about particular parts of your presentation. So one question may in fact, one answer may in fact address more than one question, if that makes sense. So going back, let's see here. Well, some about answering your slides. You had talked about tips. A few more questions about tips. One particular to the tips that you're using. And then do you sterilize them, or how often do you replace them? Maybe we'll start there and I'll queue up a couple more specific ones after that.
Sure. So for the tips, like I said, either MC6, I use those one time and toss, or the MC3 is made from a different material, so you can actually sterilize and reuse that. Just basically until you always want to check it, make sure you're getting that light. If anything funny's happened, then you toss it and get a new one. That's basically what I've been using. Whenever I use an MC6 though, I just throw it away right away. And because it's made from a different material, so not really meant to be reused.
Okay, thank you. There's a question about contact very early on in the presentation. The position is that the doctor feels contact can cause inflammation, so less contact can improve post-op. Can you get the same results and a better post-op if you do not actually get into contact?
So I've tried not contacting before. Well, with soft tissue, you're supposed to contact. But if you don't contact, you don't really cut. So you're spending a really long time there trying to ablate that tissue. And the inflammation is very minimal, actually, even when I do contact. And again, another thing you can do is just have them apply something cold right after. So with the little ones that, cold breast milk helps a lot, or you can do like sterile, they sell like this shape ice cube trays. You can do like sterilized water in it, and then you just apply that right after, and that will help with the inflammation issue if you have any. I haven't really experienced any, and most kids are pretty comfortable that same day when I call post-op.
Excellent, thank you. And just a brief reminder to all the participants that there is additional content to follow this brief question session. We just want to make sure that we can get to as many as possible. And since most are certainly specific to some of the procedures that Dr. Learn just showed, we wanted to take a few minutes and get to some of those. So a brief reminder, there is more content to follow. There is a very easy question, I think, about where you found the tongue holder.
Amazon.
Amazon, there we go.
Like I said, I actually found it on Amazon, but you can talk to your dental suppliers and they have them as well. But on Amazon, it was like $3. So it's perfectly effective. It does come from like a medical supplier, just, you're not really inserting on anything. So I feel comfortable using it, and it holds up well on autoclave and everything.
Excellent, thank you. And we've opened up the floodgates and we're getting probably 4 or 5 questions a minute. So please remember that we'll put these in a queue and get to as many as possible. You talked about your topical. I think there still might be a little bit of confusion about what you're referring to it as versus the name. Would you mind going over that again for just a moment, Doctor?
Sure, it is super confusing. The name of it, the brand of it, is called The Best Topical Ever. It is a compounded topical. You can buy it from them online. They verify your license before you do. But if you have a pharmacy around you that compounds, you can also go and ask them to compound it as well. And I could post that for you guys later if you guys have more questions about it.
Great, and Dr. Leung was kind enough to offer her contact information at the end of the presentation. So should you want to get into contact with her more directly about some of these things, again, that's another opportunity. I'm getting many, many questions about posting this, and I'll address, all of those at the end. Know that this will be available in about a week or so for you to watch it again, review, etc. So doctor, maybe 1 or 2 more before we go back to the rest of your presentation. Does that sound okay?
Perfect.
Excellent, thank you. Is the Waterlase superior to doing frenectomies in comparison to the diode? Does one hurt more over another, and is one more efficient than another?
Great question. I did mean to touch on that since I said I've done it with diode before, but yes, diode is the healing time is a lot longer afterwards. And again, I think it has to do with you causing more inflammation. Yes, with doing that, because it really heats that tissue up a lot more. Also, it does a lot more of that charring. So it is less efficient. It still is efficient, but it is less efficient for me personally. And also I find that the kiddos, especially newborns, can't nurse for at least like a full day and sometimes 2 days after that procedure. So I think they do have a lot more discomfort post-operatively versus using the Waterlase. With the Waterlase, my kiddos can breastfeed right away when they're here. So I think that's the main difference for me.
Okay, and then maybe the last one on this section, doctor, and we'll let you continue and then catch some more at the end. Does that sound okay?
Great.
Why, this is a question from Dr. Gupta, why do you go vertical first and then horizontal in frenectomies?
Okay, so from what I understand, so basically the vertical release there it allows you to really see where you need to make that horizontal cut. So if you're going horizontal first, then a lot of times you can go too deep, or maybe it's not the right place, so your release isn't full. When I release it vertically, I'm releasing that superficial tissue, basically the superficial fascia, which allows you to open it up a lot more, and that will allow you to get that full release. I think if you do it horizontal, I'm sure you could get the same results if you are familiar with, you know, the anatomy and you've done this procedure a lot. But I find that especially in the beginning, it's a lot easier for you to do it horizontally, where you're only touching the freedom. You're not touching any other tissues. And then you can open it up and you'll see all of those little strings inside, like I said, and then release those horizontally.
Excellent, Dr. Lerner. Thank you so much. I think it'd be an appropriate place to get you back into the flow of your presentation. It's going very well. We're getting a lot of positive comments, and we're excited to see what else you have in store for us.
Great. I'll try and go through this really quickly. And if, like I said, if you have any questions, my email address is at the end. I'm super happy to answer any or provide you with additional information or resources if you need it. So mostly here, we're just going to be talking about the other uses of a Waterlase besides frenectomies. So you can do hard tissue as well. Like I said, I use it all the time on hard tissue, especially like kiddos who can't stand the vibration of a handpiece. I see a lot of special needs kids. So a lot of them who are high functioning, they just don't like the vibration of a handpiece. So this is a lot more comfortable for them, especially if they don't hear any of the sound with, we use headphones and noise music. So you have a decreased need for local anesthesia by using this on hard tissue, decreased sensation on the tooth. You can do a very conservative preparation as well, just by the nature of what the laser does, which is reduce the bacteria in there. It also helps you to see more when you're doing it, because you can hear a difference between when you're in that carious tooth structure and when you're in healthy tooth structure. And then you also get a better etch of the tooth surface. And the reason for that, as you can see here, is so this one here on the left side is with a traditional handpiece. So you get a lot more of that smear layer. By using the laser, you're not doing as much of that mechanical removal, and so you get less of the smear layer, so your etch is fantastic. There's also edge setting on there as well. Sorry. So for local anesthesia, what I do is that, or what is recommended, is that you're gonna hold the handpiece about 2 to 3 millimeters away from the surface of the tooth. And that's going to be about double almost what you would hold in order to do the tooth preparation. So you're not preparing the tooth. You're going to do a restorative, rapid setting, and you're just going to move in small circles around the tooth for a minute for deciduous teeth, and then 1.5 to 2 minutes for an adult tooth. And then that's going to give you some local anesthesia for the tooth. I find that it lasts for me about maybe like 10 to 15 minutes, depending on each kiddo. But you know, in Peter, we work super fast, so usually that's good enough for a procedure. And I really only need to do that if I'm doing like an adult tooth, or if I'm doing a pulpotomy on a deciduous tooth. So how does the laser analgesia work? This is the scientificness of it, but basically it works similar to when you're jiggling the cheek, when you're giving local anesthesia, by disrupting the pain signals. And so therefore you get some laser analgesia, and it lasts a little bit longer. No, sorry. This is technique demonstration on how to do a pulpotomy. I'm going to skip it just because we're running a little short on time and I want to get to as many questions as I can. But it's very similar to how you do a pulpotomy with a handpiece. How I use it, yes, I do see some kids that I can do it with just nitrous, no local anesthesia, do the pulpotomy. Doesn't mean I don't have to use a handpiece. I have to use a handpiece to do the crown prep, but a lot of times I do crown preps without needing to do anesthesia, especially when I just need to slice that interproximal. Another way you can do it is place 2 steps before you need to do the pulp. Then you don't even really need to do as much of a crown prep, but we'll talk about that later if you need to. But yeah, when I actually do the pulpotomy, then I don't have to give them local anesthesia. And then again, that's about case selection. Like I said in the beginning, you can't do this on every kid. Sometimes you do need local anesthesia, but on some kids who are going to be great and you've treated them before and you know they're awesome, then they're totally fine. They don't even flinch and know I'm doing a pulpotomy. This is just an example of how we do a hard tissue. Oh my gosh, sorry, I didn't turn the sound off. Okay, well, you can hear the sound of the handpiece. That's what it sounds like when you do it. So it sounds like popcorn popping, so it's kind of scary sounding. So what I do first is I show them on their hand. I let them know, hey, this is going to sound like popcorn popping, but it doesn't smell like popcorn, which is too bad because popcorn smells so good. And then they laugh and they're happy. And then I let them know, okay, it's just going to feel like this. See, it doesn't hurt. It's just really loud. Again, we have headphones that are noise blocking with a movie playing normally, so they don't even care about that. But it's important for you to know and for the parent to know that it's going to sound like that, and it's fine. So I just prepared a tooth here. I actually removed a composite with this with no local anesthesia, and it was really easy because the composite melts away like butter under the laser, and you can really tell the difference. Sometimes when you're using handpiece, it's harder for you to tell, or did I get all the composite or not, but with the laser, you can totally tell. Sorry. Okay, another little kiddo here. I don't know if that's so she was a little cutie pie, super nervous. So I actually did this on her upper 6 with just a laser. So I just moving really, really tiny circles there. And I thought that was just me showing her what it's gonna feel like. And then I went ahead and started preparing the tooth. Really, really tiny circles, really close to the tooth surface. It removes all the caries, and you have a much more conservative prep. And the bond is great to it. So it just allows you to do a little less than you would with a handpiece, which is great. Being silly. Okay, and then what about the diode laser like I talked about? So diode laser adjunct. So with the my Waterlase, I also have the diode, and so I think it's great to just touch on like what other things you can do with that diode besides using it for soft tissue, since obviously I'll be using the Waterlase for soft tissue. So you can do the thing that I talked about earlier, which is called photobiomodulation, previously known as low-level laser therapy. And what that does is it basically helps speed healing time. It decreases discomfort. So if I treat anyone like a little bit older, because I keep my special needs until adulthood. So if I treat them and I need to do anything, sometimes they get a little more sore on that TMJ. So I'll do this right after, and then they don't have any soreness the next day or any of that. And how that works is basically it increases your ATP production, so that will decrease your inflammation and will reduce oxidative stress. You can also do it on any procedures that you do in the mouth, because the little red light on there allows you to do the photobiomodulation, and that will increase the healing, so it'll decrease your healing time, so you'll heal faster. And that really helps a lot for some of these kiddos or some of the procedures. After I do frenectomies, I normally do a little bit of that laser bandage, which will give you a little bit of this as well. For ortho inflammation reduction, if you work with an orthodontist like I do, then you are gonna decrease their bacterial load in all those pockets, those gums that are growing over onto the brackets. So it's gonna help a lot with that. And it's non-invasive, fast, relatively painless, and it's a good service to offer to your kiddo. And then whitening treatment, of course. So this one actually has reduced sensitivity over other types of whitening that you can do. And the reason is because the time limit on this application, it reduces dehydration, which is what causes a lot of sensitivity. It works really, really well. Effective whitening in one session, and also your RDA or RDH can perform it. So it decreases you having to do the chair time for this. So good option as well. So billing and coding, I'll just touch on super quickly. So you can do it under dental insurance. Some do cover it. I can't discuss fees here. So if you have any questions, I'm happy to provide guidance for you personally. But basically, they do tend to cover it at a lower rate than medical insurances do, because that's how it works. But it is a procedure that you can bill under medical as well. So if you're going to bill it under dental, your CDG code is D7960, but you have to specify the site on your form. So make sure you're doing that, or they're not going to pay you. And then through medical, some companies, third-party companies will do this for a fee. You can also have the patient do it themselves, or you can fill out the super bill for them, give it to them, or you can submit it to the medical insurance directly. What I normally do if I choose to bill through medical is I choose to have them pay me cash, and then I bill it through medical, and then I tell them that the medical company is going to give it to them directly, because I don't make them assign benefits. So medical super bill, I'll show you. Tongue tie release is CPT 41115, and then lip is 4089. You need to have photos and a narrative available as well, or you can do it a cash procedure. This is the medical billing form. You have to use this form. You can't use the older version, or they won't accept it. And then this is actually a third-party person who can help to discuss more about billing and coding, especially with reimbursement. This one is, one is emphasis on perio, but then they have another one here with just billing and coding, and Dr. Lau is available for that one too. And so those are really great other options that BioLase is offering these webinars as well. So we can, and if you got the email for this, you most likely got the email for that one as well, which will give you some more information on all of that. So sorry we couldn't discuss that a little farther. But again, if you have any question or need guidance, I'm happy to do that one-on-one. This is my awesome rep. Her name is Cynthia. She's great. She can provide you more info if you have laser questions. References, if you want more information, you can look up their books. So Dr. Kotlo has a book. Bobby Gahari's as an ENT. He's great. So much info on his website. And then also Dr. Baxter, if you read his book, Tongue Tied, is great as well. So thank you so much. I'm happy to answer any questions. This is my email address and one more cute pic of my little kid.